Welcome, everyone. We're going to wait just one moment for people to join. Welcome, everyone. On behalf of the U.S. National Cancer Institute, it's really my pleasure and honor to introduce this session today for London Global Cancer Week, which is a framework for monitoring progress at the intersection of women, power, and cancer. You'll see we have a stellar lineup today, and I have the great pleasure of making the first introductions to our keynote, Carolyn Taylor. But first, I want to just go through a few housekeeping notes, if I may. Advance the slides. Aha. First, session logistics. Attendees will be muted, but you're most welcome to write your comments or questions into the chat. If you use VPN, we suggest disconnecting, please, for the duration of the event. And if you can see this slide but not hear anything, please check your audio settings. You may connect your audio via computer or dial in, etc., as usual. One thing we're very happy to say is that we have simultaneous translation offered in French, Spanish, and Portuguese for this session. So please do select your language. You'll see with the arrow there, English, French, Spanish, or Portuguese by clicking on the interpretation icon. We'll do live audience polling, and the Q&A portion of this 90-minute session will be conducted via Slido. So now we encourage people to please use your phone or your iPad or what have you to click on the QR code and join at slido.com with hashtag, as you can see, 2935767, and there's the passcode. I'll give everyone a few seconds, maybe 10 seconds to do that. Okay. Now the first question, just to get us started. 1, are you familiar already with the Lancet Commission on Women, Power, and Cancer? And that, oh, wow, okay. We can see the results right here live. If people have read the report, that's great. If you've read just the executive summary, that's also great. We'll encourage you after the session to read as much of it as you can to inform the work that we are trying to amplify and to progress going forward. And that's really what this session is about today. It's about the next steps. So even if you've seen, you'll see me giving a quick overview, but then the content will be really new, I think, for everyone here online today. And we aim to build our community to support the work going forward. So it looks like 60% at the moment. We're going to stop this in a minute. We've got quite a few people who've read the report, quite a few who haven't, and some who've heard of it. So that's great. The second question is which best describes your role? And you can see there the categories: civil society, clinician, multilateral international organization, national government, patient, survivor, researcher, etc. And again, we'll give a little time here. Maybe another 10 seconds or so. And yeah, there's quite a bit other and kind of an even split with the rest, which is great. We are definitely an interdisciplinary community for those of you who are familiar with the commission, including clinicians, epidemiologists, cancer economists, social scientists, gender scholarship, etc. So I'm going to start just with a brief overview of the commission. As some of you apparently already know, we really took a holistic look, a 360 look at how, at all the intersections with cancer, women across the globe, including many of us here, women in all their diversities, are subject to overlapping forms of discrimination and inequity that impact and influence, right, power dynamics with respect to how we interact with the cancer health system, whether we are healthy people involved in cancer prevention, as individuals living with cancer and beyond a cancer diagnosis, as unpaid caregivers, as patient advocates, as healthcare professionals and as scientists working in the domain of cancer. We didn't put a Slido question on this, but think for yourselves if you or somebody you're close to is in one or more of those categories. And usually when I give this live to an in-person audience, most people can identify with this, including myself. I think I have 3 of those categories. What we wanted to do with the commission was draw attention using research, quantitative and qualitative data, to inform in which ways power dynamics and asymmetries of power influence our experiences with cancer in 3 domains: in information, decision-making, and economics. And so I'm going to give a brief overview now of the key findings and recommendations. You can refer to this beautiful infographic, thanks to the Lancet, for the quantitative data and some of the qualitative data. But here, I think it's important in this session, we're going to draw attention to the themes that really came out that are so pivotal to taking actions now that we can each take. First, language matters. The way that we think of ourselves, the way that we think of the people we are interacting with in the cancer health system, particularly, I'll say, wearing my cancer care provider hat as an oncologist, language matters. Are we blaming the patient? Do we know why this woman might have come for care only when her cancer was very advanced? If we don't ask her and really invite her in a safe space to reflect on her experiences, we risk blaming her, we risk her experiencing self-blame and missing the point that maybe there were upstream determinants like domestic or intimate partner violence, like not being the person with the agency to make decisions for herself because of economic considerations, because of employment considerations, for example. So in many countries, regardless of geographic region or economic resources, women are more likely than men are to lack the knowledge and the power to make informed cancer-related healthcare decisions. Women are also more likely than men in many situations in many countries, and this is not high income versus low and middle income, which is kind of a really rough tool anyway, as many of us know. In many situations all over the world, women are more likely than men to risk financial catastrophe due to cancer, and this has repercussions for their families, communities, and societies, even when cancer care is available. I just attended a session where we talked about global health financing for cancer, and I was reminded of the importance also of quality care and respectful care, which is essential. So if a woman feels that she has to ask her husband, okay, not just for permission for care, but for permission to maybe sell assets to receive care, and that care is of poor quality, then there are multiple tragedies unfolding, right? So we want to be able to overcome this through these collective actions that we'll talk about today. Another one is that unpaid caregiving for cancer, as well as other chronic conditions, is primarily undertaken by women. We're lucky to have a member of, actually, the lead of our cancer economics group here, working group on the commission, Rachel Nugent, who will speak to this. New methods are needed to estimate the true value of women's work in cancer care. And women in the cancer workforce. Unfortunately, like in every other domain of society, report. So there's so much that isn't reported, but at least we know that we see reports of frequent and severe experiences of gender-based discrimination, including bullying and even sexual harassment. There have been reports out of the US and the UK, just as we know this occurs in every country to some degree. And these are issues of power that impact our experiences also as cancer health providers and cancer researchers in terms of our opportunities to advance and achieve optimal outcomes for ourselves in terms of our professional development. And we also know that patriarchy overall dominates all of cancer care research and policymaking, and that those in positions of power are making the decisions of what is prioritized, funded, and studied. So that's the bad news, right? Patriarchy is a system of oppression that we've all lived under, whether we identify as male, female, or other, right? But what we're really about today is solutions. So let's get to some of those solutions. Our recommendations, first of all, what and also who. In a moment, you'll hear about how. I think you now know why. Who should act on the recommendations? So international organizations, including multilaterals, national and also subnational governments. Think about how much policymaking, even in the municipal setting, the state or provincial setting, can really help to drive action. We saw a lot of that in the tobacco control movement, in fact, that then sometimes is elevated to the national level. Researchers and research funders have a role to play, as do, of course, civil society, including people with lived experience, as you'll hear in a moment, much more from Carolyn Taylor, and also the private sector. I'm not going to go through this in a lot of detail, but just to say, please have a look at the report. You'll see our recommendations. The overarching recommendations is to ensure that data, good quality data on sex, gender, and other social and demographic factors are routinely connected in all cancer-related health statistics, publicly reported and updated. That sounds easy, but it's not actually. It is challenging. And this is a bit of a shout out to support cancer registration that includes our opportunities to collect and then be able to disaggregate data based on sex, gender, and other considerations. We are an intersectional feminist commission. So we think, I hope you all agree, it's incredibly important to look at how those power dynamics play out when people are also identifying perhaps as female and as a person of color, a person living in poverty, somebody who's structurally marginalized, etc. This is all very important to address. We want to achieve the ultimate goal of gender transformative health systems for cancer, and that includes on the prevention and early detection side, as well as the cancer health system in terms of treatment, follow-up care, survivorship, and palliative care as well. We want to develop, strengthen, and enforce existing laws and policies to reduce known exposures to cancer. I mentioned tobacco. Of course, we also know that alcohol is now emerging, as we've known for some time, but really now emerging with a lot of excellent quantitative data to show just what impact alcohol has on cancer risk for women as well as men. Co-creating accessible health systems, as I mentioned, and researching, monitoring, and acting on emerging risks. The emerging risks are critical here because it was only once we started really looking at it and just having discussions with colleagues in our partner agencies, such as the International Agency for Research on Cancer, part of the World Health Organization, that products and chemicals and products that can cause cancer are only studied if they're brought to the table for the process that leads to the systematic reviews, et cetera. And so we found in our commission work that there are chemicals in products that are primarily marketed towards women for which there is already either US FDA or EU or other major national and international agencies that have put out advisories or outright bans. Products primarily targeting women on the basis of these ideas about beauty, for example, like chemical hair straighteners. We want to ensure equitable access to cancer research, leadership, and funding opportunities for women. As I said before, that patriarchy influences all of those decisions. We need to interrogate how we make those decisions and who is at the table. Gender competency framework, you'll hear a bit about from my colleague, Professor Nazik Hamad, who's one panelist today, absolutely essential. And finally, in terms of economics, we are recommending the development and validation of a feminist economics approach to investment cases and other economic evaluations of cancer, and to establish and enforce pay standards for cancer caregivers that are fair, equitable, and inclusive. We've had a lot of attention now on the Commission report. We're very happy from last September when we did the global launch at the Graduate Institute of Geneva in collaboration with a number of partners, including the US NCI, eCancer, and others, the UICC. We made the front page of The Guardian, which surprised us, but we've seen a lot of interest from men and women and people of all genders and all disciplines who want to know more about this work and be part of the solution. So that's what we're going to get to in a moment. We just saw last week the European Cancer Organization publish a major report on women and cancer, which was, in their words, influenced heavily by our report. So taking the actions, making it local, looking at your national data, et cetera, is really key. And a little shout out here to the NCI in collaboration with the NIH, National Institutes of Health, Office of Research in Women's Health. We had a 4-part workshop on sex and gender differences in cancer. And City Cancer Challenge, CCAN, you see on the slide above, also just launched their gender strategy based on our recommendations on our work. So we're really happy to see this being taken forward. Now we need to talk about evaluation. We're going to talk about the Lancet Commission monitoring and evaluation. My colleague Elise Garton will talk about this in a moment. I just want to make sure that we now move to, one slide too many. I just want to introduce now, it's my pleasure and honor to introduce Carolyn Taylor. You're going to see her pre-recorded message, but she'll be here live for the panel discussion. Carolyn is currently in Brazzaville working on a WHO program for the Global Breast Cancer Initiative. Carolyn is a global leader and advocate in support of cancer care. As founder and executive director of Global Focus on Cancer, she combines her lived experience and expertise to create partnerships and establish culturally relevant, evidence-based cancer awareness and support initiatives in low-resource settings. Carolyn was a contributing author to our report and played a pivotal role in forming our Patient Advocacy Committee. She also serves on the steering committee for the WHO Symposium on Meaningful Engagement, and is a current commissioner for the Lancet Global Health Commission on people-centered care for universal health coverage. She's a highly sought-after speaker at global cancer conferences, co-founded and co-chaired the annual Southeast Asia Breast Cancer Symposium in 2015, and she has many other roles, but I think in the interest of time, I'll pass the baton and we'll show Carolyn's video now. Thank you so much.
So in my role convening the Advocacy Committee and as a contributor to the advocacy section of the report, my focus has been on highlighting the transformative role of advocates, especially those with lived experience, in shaping equitable cancer care. Advocacy in this context goes beyond awareness. It's a vehicle for reimagining and advancing research, education, and equitable access. It ensures all voices are considered, particularly those traditionally marginalized from decision-making processes. The Commission's findings reveal that significant progress in women's cancer care requires dismantling entrenched power dynamics, shifting from hierarchical systems to inclusive, community-driven models. Historically, decisions about cancer care have been made in distant top-down frameworks that often exclude the very people they aim to serve. This approach perpetuates disparities in care quality and accessibility, particularly for women who are disproportionately impacted by cancer. To activate the Commission's recommendations, we must elevate women to leadership and advocacy roles, centering their insight in policy and healthcare system priorities. Advocacy rooted in lived experience isn't just beneficial, it's essential to aligning healthcare systems with the realities of those affected. This model of advocacy bridges the gap between policy intent and practical impact, making healthcare more responsive to women's social, financial, and psychological realities. In today's presentation, I'll discuss how we can harness advocacy to drive these shifts, ensuring that the Commission's recommendations lead to real-world, community-centered change. Creating an equitable cancer care system requires recognizing women not just as patients, but as essential contributors to policy and practice. This involves elevating women with both lived experience and professional expertise to leadership roles, fostering a healthcare model that values their insights and strengthens patient-centered care. Women leaders, whether drawing from their personal experience or professional expertise, bring essential perspectives to shape care systems. Programs that encourage this dual advocacy and leadership approach create a unique platform for transformative change, blending real-world knowledge with strategic oversight. Imagine a system where women leaders champion culturally competent care and responsive support that addresses the full spectrum of challenges faced by those impacted by cancer. These leaders, informed by their own experiences or those of their communities, can become powerful agents for change, making healthcare more inclusive and responsive. Empowering women in leadership and advocacy ensures that their voices shape policies and practices, promoting a culture of accountability and empathy, and fostering a shared commitment to excellence and compassion. Data holds immense power in advocacy, yet barriers around access and publishing limit its transformative potential. Many advocates, particularly those representing marginalized communities, struggle to access reliable, localized, and peer-reviewed data that would provide a fuller understanding of health disparities. These challenges extend beyond access. Advocates often lack avenues to publish or disseminate community-focused insights within traditional peer-reviewed platforms. This lack of equitable access creates critical blind spots, limiting the evidence base that informs policies and overlooks community-specific needs. However, these challenges present a compelling opportunity for collaboration between advocates and researchers. By working together, they can co-develop data frameworks that are not only scientifically rigorous, but are deeply grounded in the real-world experiences of communities. This approach enables the collection of disaggregated, localized data that shines a light on gaps in care access, quality, and equity. When advocates have access to relevant peer-reviewed data, their advocacy gains a robust foundation, allowing them to back community-driven insights with solid evidence. By highlighting disparities and giving voice to those most impacted by systemic inequities, this data support calls for equitable and responsive healthcare solutions. Furthermore, establishing pathways for advocates to publish in peer-reviewed forums helps ensure that community perspectives contribute to a more inclusive, evidence-based, and drive reforms that prioritize patient-centered care. With access to relevant data and publishing opportunities, advocates can help shape a healthcare landscape that includes the full diversity of community experiences. In many healthcare systems, women's unique needs are often overlooked, especially in cancer care. Care tend to exclude community input, missing the nuance of individual, social, and economic challenges that shape each patient's reality. Advocacy has the power to disrupt this imbalance by centering health on the very community it serves. The Commission emphasizes that significant progress in women's cancer care requires a model that goes beyond treating cancer itself, addressing the social determinants of health, factors like financial strain, mental health, and social isolation that profoundly impact outcomes. The lived experience stories shared in the report illustrate that women facing cancer are more than just patients. They are caregivers, breadwinners, and community members who bear significant financial, social, and psychological burdens. Their experiences reveal that a comprehensive approach to healthcare must account for these layered challenges by extending care beyond the clinical walls. Sarah from Mexico, for example, experienced financial strain, social stigma, and isolation while navigating treatment. Addressing cancer involves not just medical treatment, but support systems that acknowledge her economic role and emotional needs. This calls for healthcare systems to be restructured to provide holistic support, considering the unique and often compounded pressures women with cancer face. Similarly, Esperance's journey in Rwanda demonstrates the struggles of navigating healthcare systems while also managing the logistics of travel, family responsibilities, and the financial burden of cancer treatment. Her story reveals the isolation and hardship that can come with a diagnosis, issues that are often sidelined in traditional models of care. By shifting focus to include these broader determinants, we can create healthcare models that truly empower women, valuing their roles within families and communities and recognizing their resilience in the face of these multifaceted struggles. This shift in power dynamics is transformative. By including women's voices and experiences, healthcare moves from a clinical-only model to one that is holistic and community-centered. It's an approach that not only meets medical needs, but also builds a comprehensive support system that addresses the emotional, social, and financial aspects of care. This collaborative process positions healthcare as an adaptable, resilient system where women are not passive patients, but active partners in creating solutions tailored to their lives. In sum, when communities and advocates shape healthcare, we create a model that's truly inclusive and equitable, a model that sees and supports women as whole individuals, recognizing the many layers that make up their care needs. Challenging biases in healthcare is crucial to creating an environment where women feel respected and fully. When feel valued by their providers, they're more likely to engage actively in their own care. Yet without strong, dedicated efforts, these biases often remain unaddressed, impacting the quality of care women receive. Pushing for policies that mandate gender sensitivity and cultural competency training among providers is an essential step. This training equips healthcare professionals with the skills to understand and respect women's unique needs, ensuring their voices are both heard and valued. By integrating real-world experiences shared by women into these programs, we give clinicians insight into how biases affect patient care. This firsthand perspective helps cultivate a new generation of healthcare providers who prioritize empathy and respect in every interaction. This shift moves the system toward a more inclusive and respectful model of care. Women become more than patients. They are acknowledged, respected, and valued for their individuality and agency. In this transformed healthcare landscape, empowered patient voices join with trained providers, forming a partnership that leads to better health outcomes and a truly equitable healthcare system for women. Advocacy at the policy level provides a foundation for deep systemic transformation, tackling the structural causes of inequity that hinder women's access to comprehensive cancer care. Legislative reforms focused on gender disparities address the unique challenges women face, from limited access to equitable care and support services to the financial burdens associated with caregiving roles. Policies for fair compensation empower caregivers to support family members without financial strain. Moreover, advocating for gender equity and research funding keeps women's health priorities at the forefront, ensuring that prevention and treatment gaps are addressed. This includes prioritizing research that examines how social, biological, and environmental factors uniquely impact women, leading to more targeted and effective interventions. Policy changes like these don't just offer immediate improvements. They build a healthcare system with resilience and equity at its core, creating a foundation that will benefit women and communities for generations. Through these combined efforts, advocacy lays the groundwork for a more inclusive, responsive, and just approach to cancer care, where women's health needs are prioritized and addressed systematically. As we close, let's underscore the transformative role advocacy plays in bringing the Lancet Commission recommendations to life. These recommendations aren't merely ideals. They offer actionable pathways for reshaping cancer care for women worldwide. But this transformation relies on advocacy that is rooted in the lived experiences of those most affected. Advocacy is the mechanism that holds healthcare systems accountable, demanding changes that resonate with real community needs. Without it, disparities and gaps in care will persist, leaving women underserved and undersupported. Effective advocacy moves beyond surface level fixes and drives a deep systemic shift that prioritizes the comprehensive needs of women across all aspects of their health. By centering advocacy on the lived experiences of women, we are not just imagining better care, but actively working toward it, ensuring that change is immediate, impactful, and sustainable. This commitment turns vision into action and creates healthcare systems that truly recognize, respect, and respond to women's needs. The future of women's health and cancer care hinges on collaboration between advocates, researchers, clinicians, communities, and policymakers. Together, we're building a supportive healthcare system that prioritizes women's needs at every stage. Advocacy becomes the foundation for an equitable, inclusive healthcare system, creating a world where women's health is central, valued, and effectively addressed. And with that, I will say thank you all so very much for your attention. Thank you so much.
Thank you so much to Carolyn for giving that great keynote address. I think we're just sort of transitioning from the video back to the slides here for a minute. It's tough to follow that up, but I'm going to try. So my name is Elise Garten. I am a health specialist here at the U.S. National Cancer Institute Center for Global Health. I have the unenviable job of talking about our methods and processes in building this evaluation framework, which a little bit drier than what you've just heard, but I think really important to the work. So I'm just going to do sort of a brief overview of what we did and why before we jump into our panel discussion. Oops, there we go. So perhaps it is obvious, but I think worth addressing why evaluate in the first place. So A sort of formal evaluation is not a required step of a Lancet Commission and is not something that most of them do formally, again. But I think the work of the Lancet Commission on Women, Power, and Cancer extends far beyond the report. And there's a lot of things that monitoring and evaluation can do related to the commission. It can serve as an indicator of research and implementation priorities, can measure progress and identify gaps early in implementation. It allows for reflexive learning and adaptation, and provides benchmarks for scaling efforts. And evaluation is particularly valuable for this Lancet Commission, since one of the key findings that Ophira looked at is the scarcity of related research and available data. If we measure, we can know more. And so it's really sort of a bidirectional approach to understanding more about the intersection of women, power, and cancer. So the first thing we did as part of this monitoring and evaluation, or M&E effort, is come up with a framework, and that's what you're seeing on this slide. It's based on the traditional log frame that many of you may be familiar with, and it starts out as sort of the input there in that black box is those 10 key recommendations that Ophira showed on the slide. And from there, we sort of measure on two planes. So that top plane is our dissemination, those processes and outputs, which is all of the events, publications, blog posts, conferences, etc., where we've shared the findings and the recommendations of the report. And then that bottom plane looks at the processes, outputs, outcomes, and impacts of our implementation. So that's all of the work we've done to achieve these recommendations at all levels. You'll see that sort of dotted line in between dissemination outputs and implementation outcomes. And that's frankly a relationship that we hope exists between dissemination and implementation, and that we will try to measure. I think it's also worth pointing out that very last box furthest to the right on your screen, those implementation impacts. That's really the end goal of this work. And that's the improved quality of life and involvement of women that Carolyn just spoke about in that keynote. And frankly, that is really hard to trace back to the report. And so most of what we measure looks at the processes, outputs, and outcomes. And the aim, of course, is those final impacts. So presenting this framework optimistically and looking at a lot of those sort of interim steps that we can measure iteratively over time. So what did we actually do as part of this work group process? We had a subset of the commission. We had 12 commissioners, 1 mentee, and 4 external M&E experts that engaged in a modified Delphi process to create that framework you just saw and identify key performance indicators. And that work group was very interdisciplinary. We had epidemiologists, clinicians, researchers, cancer economists, evaluators, patient advocates, and more. And they sort of did this in 4 steps. First, proposed indicators based on a scoping review and their own expertise. And that was really throw in every indicator we could possibly think of that might link to these recommendations. Then we whittled that down by screening them for duplicates and feasibility, took that set and prioritized them based on sort of what was most relevant to the commission, and then stratified them into 2 tiers following sort of a WHO framework where we look at a higher priority and a lower priority tier just to make it easier for folks to actually adopt and implement these indicators. And what we came up with from that was 31 total indicators, 20 in that tier 1 of the highest priority, 11 in tier 2. And there was a real emphasis here on their relevance to the commission's 10 key recommendations, their technical feasibility, and their alignment with commission priorities. I'm not actually going to show you all 31 of those indicators. They don't fit on a slide. They're not the most thrilling to read to individually, but we're going to talk through them generally and dig into a few specific areas during the panel as well. So again, thinking about these indicators collectively, I think there's a lot of enabling factors to those. So one is strong institutions. So for example, the International Agency for Research on Cancer that has the potential to monitor and evaluate a lot of our progress on things like emerging cancer risks for women, which is one of the recommendations that you saw in Ophira's slides. There's also a lot of existing initiatives to support this work. A great example would be the Union for International Cancer Control's Global View of National Cancer Control Plans. This is something they complete every few years, and they look at all of the existing NCCPs to understand what is included in national cancer policies. And we've spoken to them already about a lot of opportunities to measure and find some of these indicators in existing NCCPs. There's also a lot of local or disease-specific studies that can provide baseline data and methodology. So we spoke a lot about technical feasibility and how challenging some of these indicators are to measure, and that is often the case at a global level, but many of them have already been measured at a local level. And so these individual studies provide a really good basis for us to continue that research. And finally, I think there's a broad interest and applicability of these indicators at all levels across all contexts, and just a few screenshots there of recent sessions and reports that reflect that. All that being said, if evaluating this was easy, it would already be happening. So there are, in fact, a lot of challenges. The first one there is technical feasibility. So as I've mentioned, we really tried to prioritize indicators that were possible to measure, but in many cases, that is, at least right now, just the case at a local or national level. We understand data collection is complicated, but we felt it was important to put some of those aspirational indicators out there to inspire institutions to try to measure them. And part of the reason that can be hard, as I've mentioned, is a lack of baseline data. It can also be difficult because there's a lack of standardization of concepts as fundamental as gender. And that really makes comparison between countries or institutions or industries difficult. Political will is another challenge to implementation, and that, of course, varies across contexts and over time. And there's a lot of contextual differences that make sort of writing a seemingly simple indicator actually quite challenging. So for an example, in the US or the UK, it might make sense to assess a lot of our organizational metrics at a cancer center level. Those are really the facilities in the US that are providing most of the cancer care at a high level. But in other countries, it's a network of differently tiered public and private hospitals. And so how these indicators get measured and how they get evaluated differs quite a lot between contexts. And the last major challenge, which we've alluded to several times and really want to focus on for the remainder of this session, are questions about accountability. So who is responsible for doing all of this evaluation? Who's responsible for reporting it, both within their own organizations and publicly? And who's responsible for ensuring and enforcing that evaluation and reporting? So we're going to address a lot of these questions and challenges in the panels, but we also really want to hear from you all as our audience, and everyone here is really an important stakeholder in this effort. So I'm going to go back to our Slido here, and I'll give folks a second to either scan that QR code or re-log in at slido.com. You can do this from your mobile device or from your computer. And go ahead and take a look at that next poll question. What are examples of policies or programs that could benefit from evaluation with a gender and intersectional lens? And these can be things that you've worked on in your organization, or just something that you're familiar with or read about or even heard about in this presentation. Just give folks a few minutes and those results should start showing up on the slide. See a patient navigation program for breast cancer patients, workplace wellness, provider-patient communication, quality improvement, patient safety, national education policies. I think it's cool to see some things pop up here, and there's plenty in the report that's discussed as well that are not necessarily specific healthcare policies or programs, but are incredibly relevant. Referral and counter-referral programs, more about patient navigation, training, fellowships and publicly funded research grants, insurance, parental accommodations, family medical leave. These are all things that we have tried to address in some of those recommendations and indicators too, but I think the breadth of examples that we're seeing here is a good representation of the breadth of areas that are really impacted as well. So this is great to see. Cancer in the workplace. Also, if you are typing, Feel free to keep going. We'd love to see these coming in, and we will have them all saved, but I'm going to move on to our next question. So the second question, again, coming off those questions of accountability, who should be accountable for monitoring and evaluating progress towards our recommendations? So go ahead and feel free to type in your answers there of stakeholder groups broadly, individual organizations or institutions, whoever you think might be relevant in this accountability framework. Government, hospitals, the NIH, education. I think the size of the word is related to the number of responses. So there seems to be a big movement for government here. We've got a lot of other things: community, health insurance, CSOs. I think that probably means civil society organizations, National Cancer Control Committee, community leaders, advocates, multinational organizations. A lot here for advocacy groups as well. Health financing organizations, international partners, Ministry of Health. If you remember that slide that Ophira presented with those key stakeholders, I think that's sort of a good overview of who might be responsible for a lot of these, but it's great to see a few more specifics here, and a pretty clear focus on government and advocacy groups, at least from our responses. All right, thank you so much for answering those couple of questions. We are going to move on to our panel discussion, and so we're going to do this in two parts. The first is going to be a moderated panel discussion, and then we'll follow that up with audience Q&A. So if you are already in the Slido, I think you should be able to see a Q&A, and so you're welcome to drop questions in there now. We'll get to them in the second half of this part. But for now, I'm just going to very briefly introduce our panel. Their full bios are available on the session website. If I were to read all of those, we would be here all day because they're all incredibly accomplished and have really fascinating bios. But I will just introduce them briefly, and then we'll kick off with some questions. So we have 5 panelists today. We have Dr. Ibtihal Fadil from the Eastern Mediterranean NCD Alliance based in Bahrain, Dr. Nazak Hamad from the University of Toronto in Canada, Dr. Jennifer Moodley from the University of Cape Town in South Africa, Dr. Rachel Nugent from the University of Washington in the US, and Ms. Carolyn Taylor, our keynote speaker from the Global Focus on Cancer in the US. And she is joining us live now in Brazzaville this week. So just please do forgive sort of any iffy Wi-Fi connection we have during the panel. I think we can take this slide down and we'll get everyone's faces up here. Fantastic, thank you. So I'm going to start off with sort of some pointed questions to each of our panelists. I'm going to use just first names from here on out. I think we all know each other quite well. And so the first question I have is for Jen. What advancements do we need to see at a health system level for women's stories to change?
Thank you, Elise. So Carolyn spoke about some of the stories that we highlighted in our commission report, but people, I'm sure, have heard of women's stories in all of their interactions. And if we look at women's interactions with the healthcare system, what do these stories highlight? So what do we want to change from? What the stories highlight are that women experience barriers to accessing cancer care in a timely manner. This may be for a variety of reasons, not being able to prioritize their health care, lack of agency, financial reasons, cultural barriers. So there are various barriers to even getting into the health system. And then when they access healthcare, you heard Carolyn mention the disrespectful care often received. We had a story in the commission report, which will be familiar to many women, where women are simply not believed, and so they're sent from pillar to post with their symptoms. And then, really importantly, women are not seen in their entirety. So issues like fertility, sexuality, these things are often ignored, and the woman becomes seen as a cancer case. The rest of her is totally ignored. So practically, what can the health system do to address barriers to accessing care? So we can look at making health services available, more available, and it will depend on the particular setting. Things like decentralizing services so that they are closer to patients. Then considering various approaches we now have, such as self-sampling for human papillomavirus, and in some settings that can really help more women access care. But I think we also have to be careful with these newer technologies so for example, like mHealth, which is being promoted a lot, mobile health, we need to be careful that they actually don't increase inequity for women. So when we introduce these new things in the health system, we need to check that they're not making things worse. Obviously, community-based programs need to be undertaken to increase awareness so women are aware, but those programs need to also address the specific risks that women face, including things like exposure to environmental toxins. And then I think the health system has a really important role to work with other sectors to address the access barriers. To show the other sectors the impact of the impact their sector is having on health and well-being. So there's an important collaborative role there. Then once a woman comes into the health system, we really need to change those encounters. So women need to be able to receive holistic healthcare. We need holistic healthcare models that integrate care for women's life stages. So they may need things like advice on pregnancy or access to services about pregnancy, issues related to menopause or sexuality. So all of these services need to be integrated so we see women in their entirety. Importantly, women need to be included in research studies that help happen in our healthcare settings. We also want to eliminate bias and discrimination in healthcare, and I'm sure Nazik will speak more to what our workforce can do, but we need to do this along the entire health system. So from policy level all the way down to the individual interactions healthcare providers have with patients. Essentially, we want women to receive respectful care that's bias-free diagnostic interventions and bias-free treatment. To do all of this, we need to obviously be able to measure things in the health system. So we need to collect the data that's disaggregated by sex and analyzed with a gender lens. To me, we definitely need more women in leadership roles within the healthcare system. And all our policies, not just our cancer policies, but our policies need to take into account women's health needs. And we should be monitoring that regularly. Are those needs being met? Where are the gaps? Because that will then guide in an ongoing manner what the health system needs to do so the stories can change and be more positive. Thanks, Elise.
Yeah, thank you so much. That was really a wonderful tour through, I would say, the greatest hits of the recommendations and the indicators, and really appreciate that answer. As you sort of mentioned, health systems are obviously made up of people in the cancer and the health workforce. So I'm going to ask Nazik to share a bit about how cancer workforce training needs to change to ensure provision of respectful and gender transformative care, and how we can do this. I think you're muted, Nazik.
Sorry, I'm in the hospital, so there's some maybe construction going on. Hopefully it will not drown while I talk. So yes, I think everyone has mentioned the role of the workforce. We know that there is no cancer care without a cancer workforce across the continuum. Women in all their diversities at risk of receiving suboptimal, guideline discordant, and sometimes outright disrespectful care. And so one of our priority action from the in the commission is integrating a gender competency framework in the education and training of the cancer workforce. We know that there is increasing adoption of competency-driven education that should be responsive to local context and population needs. And we know that sex and gender-specific issues require focused attention for optimal care delivery. And this the gender competency framework was inspired foremost by women's stories, because as everyone has mentioned, most of these stories in the commission and the ones we live ourselves involve interface or interaction with a health worker. And this is also inspired by feminist approaches to medical education and our intersectional feminist framework. And we know, as Bell Hooks, the African-American feminist, has said, whenever women struggle with breast cancer and face better care than ever, this is feminist. So the framework is, what is it? It's a curated set of gender competencies for the workforce that could be tailored training, and so that they can incorporate it in their practice and can be tailored to the specific context, the workplace, and the particular health profession. And when we say competency, we mean habitual and judicious use of communication, knowledge, technical skills, clinical reasoning, emotions, values, and reflection in daily practice for the benefit of the individual and the community being served. So hence competency-based medical education. And there are two categories of competencies. One of them are biomedical, which are traditionally known as medical expert or medical knowledge. And these relate to sexual dimorphism in cancer, disease susceptibility patterns, the difference between men and women in pharmacodynamics, pharmacokinetics, genomics, toxicity, response to treatment. So we know as a medical oncologist, women are more, give chemotherapy, women are more prone or at high risk for chemotherapy-induced nausea, vomiting. And there are actually ways to screen for that. And also fertility issues, as is mentioned. The other type of competencies is structural competencies. These mean that social determinants of health and structural determinants are taken into consideration in the encounter, and that social forces are amenable to analysis, investigation, and intervention, and addressing molecular reductionism. So the patient is not just the molecular signature of their tumor. And so when it comes to the competencies themselves, the framework is comprised of 4 overlapping and interconnected domains. And I encourage you to look at the table in the commission report. Provision of care. These include communication, guideline concordance, the specific toxicities for women. So for example, immunotherapy, women can get more side effects and how to manage that, addressing the work, and then another domain is a workplace and the professional team, looking at the role of implicit bias and microaggression in the workplace, and then health disparities, understanding sexual and gender minorities, recognizing misdiagnosis and mistreatment that come from ignoring structural factors. And of course, the last one is policy, equity, and health system issues related to contribution of culture of quality improvement in addressing the workplace and access to care. So what are the strategies for integrating these into training and professional development and the curriculum? We need innovative pedagogical strategies, the way we teach, faculty development. We need to assess the trainees and in these competencies, and also we need to evaluate the training programs and see whether they are incorporating these, and we can embed these into accreditation standards to make sure they are implemented and ensure the Global South is an equal partner. And who will do this work? What are the enable action? Is actually all of us, accrediting and licensing bodies, academic institutions, where the training programs are, civil society organization, advocacy organization, professional bodies like Awartic or ASCO. It requires a lot of activism, critical inquiry, and utilizing a feminist praxis and equity lens. And of course, raising the profile and funding the research that goes into evaluation of the workforce, education, and performance. And again, it's not only workforce performance or the determinants of workforce behavior, and not only just the training. We need to also incorporate policies that make sure that the workforce is very well employed, that there is not a lot of what we call it, high volumes clinic, high volume workload, and we need to have adequate quality monitoring and metrics for the workforce to address all of these gaps that we can see in the workforce. So I call on everybody to interact, to get familiar with the competency framework, and it's actually a work in progress. So we need people to engage with it, critique it, and research it. So, and that these competencies should be maintained lifelong. Thank you.
Thank you so much, Nazik, for that really tangible explanation of the competencies and the call to action from everyone here. We're going to take another jump into health economics, and I have a question for Rachel. How have economic indicators been used to further global health goals generally, and how can they be used to advance progress towards the Commission's recommendations?
Thank you, Elise. I will give you two examples, not just one, but two examples of ways in which we can use economic indicators to help us understand progress, to help us monitor, and to encourage and guide change. The first is very simple. The second one is a little harder. So I'll go with the simple one first. And it's the old maxim that economists use all the time, which is follow the money. So there are lots of different ways that we use to track where money is being spent. That tells us a lot about priorities. It tells us a lot about what kind of outcomes we should be able to expect. It tells us about unmet need gaps in what is being delivered relative to the need. So one example of that, well known, is the Abuja Declaration that was passed by African countries in 2001 to commit to spending 15% of general government expenditure on health. So that is very famous. It's been around for a long time. It was a very solid, very clear economic measure of a commitment to health. Sadly, only 2 countries in the region have achieved that goal. Currently, only South Africa is meeting that goal. Even though the Abuja Declaration was recommitted to just recently in 2023. So across Africa, because I just was on a call this morning where these numbers were presented across Africa, the percent of general government expenditure spent on health ranges from a very low 2 to 3%, up to the high that South Africa has, around 15%. So that's a very, very sort of aggregate indicator, very clear. People get it, and I think we understand that that can be an important benchmark, to see commitment and to reflect progress. Let me turn to a harder one, and we worked on this in the Commission report, and that is to understand the value. That's economists grapple with value, and value can be measured very simply in dollars, but that's not really a good measure of value. Value happens when something is produced that people value. So caregiving for cancer is very valuable. It's valuable to a person that is receiving care. It's valuable to the families of those who are living with cancer. It's valuable to the caregiver themselves and to society. And yet we don't put it, generally that care is unpaid. We don't have good price tags for that. but it's very important to try to measure that value. So in the commission report, we did, my colleague Gavin Allman did the heavy lifting on this, and we produced, and then you can find it in the report, 2 different ways to measure value of unpaid cancer caregiving. And just to shortcut here, those measures across 5 countries, because we didn't have adequate data to go beyond that, but across 5 countries, the value of unpaid cancer caregiving ranges from about 1% to almost 4% of current health expenditures in those countries. 2 different methods. One is, well, what else could the caregiver be doing where they would get paid? So that gives us a sort of proxy for the value of that caregiver. And the other measure is the opportunity cost. What would we have to pay? Sorry, the first one was opportunity cost. It's still early here in Seattle. The second one is the proxy, which is what would we be paying a caregiver if they were coming into the home instead of that unpaid worker. So one of the problems was that we don't have adequate data across countries, and I'll just turn to one of our recommendations to wrap up here, which is that we do need sex and gender disaggregated data to be able to demonstrate the different impacts, economic impacts, as well as the economic value of cancer affecting women compared to men and other genders. And we've called for that kind of data, and that's especially important for economic measures and economic analyses. We just finished a study that's been published in eClinical Medicine about 2 weeks ago on a breast cancer investment case in Kenya. And breast cancer largely affecting women, of course, we didn't have to worry so much about sex disaggregated data. The data we had was about women. But for many, many other cancers, we really do need to be able to break that down into who is being affected in order to be able to produce those economic data. And having that is the start to a feminist approach to cancer economics, to really be able to change how we look at the value and how we look at how much is spent for this. So I'll turn it back over to you, Elise. Thank you.
Yeah, thank you so much for those 2 examples and tying it back into our recommendations and indicators directly. The next question I've got is for Carolyn, who I know has been in and out with Wi-Fi, but if you are available, I think you talked a bit during the keynote, and we've thrown it into a few responses here too about women's representation. So curious why women's representation and leadership in all areas, research, advocacy, and clinical practice, is so important to achieving these recommendations. We may have lost Carolyn right as I asked this.
Yeah,
I think so. All right, let me move on then. We'll see if we can come back. So I've got another question for Ibtihal. Curious what changes to global policy might best advance our recommendations, and how we can best work with global and multilateral organizations to accomplish this.
Well, thank you very much. I think we start with the cancer prevention. Most of the policy related to cancer prevention, although they are currently available, however, they are not really enforced in most of the countries. So in terms of the cancer prevention, if we take breast cancer as example, we know we need to enforce the policy related to breastfeeding. And breastfeeding, there is a lot of policy in breastfeeding during the workplace, hospital friendly breastfeeding. All these has to be enforced to reduce the incidence and prevent breast cancer. Knowing that like around 5% of breast cancer could be, the risk of breast cancer can be reduced based on study if the women breastfeed for 12 months. This is an example. And there is also recommendation by WHO of breastfeeding. So these are a policy to prevent cancer in general. Tobacco control is a major thing. So implementing and enforcing tobacco control measure like the WHO of CTC. This will reduce the cancer in general, and especially for women, obesity control. And we're talking about policy related to nutrition, and to collaborate with like World Obesity Federation on evidence-based policy to reduce obesity. Policy related to gender responsive gender-related policy. So these are also have to be, we are promoting in the Lancet Commission report for any policy related to gender responsive. So there is a guideline and policy that has to be established or enforced for recognizing this issue. And we need to also to focus on policy related to reduce the socioeconomic disparity. Women in most society, they have affected by these issues, socioeconomic disparity. Policy which can or lead to empowerment of women. We've been talking a lot about issue of women power and having less power in terms of decision making for her health. So we have to enhance and created a policy that empower women and empower women, especially in area of decision making, whether for her health or whether to be an active role in as a researcher, as a leader, as a decision maker. In terms of what organization we want to work with, I think first I should say we have to leverage the next UN high-level meeting on non-communicable disease, including cancer. And this is an excellent opportunity to promote and advocate for policy, which we are referring to. That is a gender empowering women and women reducing the risk of cancer for women through these prevention policy specifically. We have to engage other partner and important partner like key stakeholder like the UN, WHO, other organization which could be supporting and to enhance the policy and advocate for gender sensitive policy. Important things we need to advocate for increasing funding for this issue. So we have many organizations that are currently able or can be leveraged and used for increasing the funding for cancer prevention program and enforcing the policy. We have to align this strategy and our global thinking with the Sustainable Development Goal. So empowering women, reducing the risk for cancer for women, this all align with the sustainable development. Without these, we cannot reach the Sustainable Development Goals. So I will stop here and we might add later. Thank you.
Yeah, thank you so much. Helpful to hear the explanation too between some new policies that we may need and some existing policies that just need to be implemented better. So we have talked about a lot of work to do across a lot of different areas. So I want to wrap up this portion of the panel by looking ahead on a little bit more of an optimistic note. So I'm going to give you all just 30 seconds to say one thing that has made you the most optimistic about our ability to achieve these goals and create better stories for women and cancer in the future. And I see Carolyn has logged back on, so I'm going to see if we can snag her to respond first if she's available. Okay, maybe not.
Sorry, I can try, but I'm
Awesome.
not sure that it's gonna work. So I'm
So far,
sorry
so
because
good.
I haven't actually been able to hear anything. I got kicked off 5 times and keep trying to come back on. So I'm really sorry to miss everyone's what everyone else was saying. I would say for me, what's the actual commission itself and the work and the unity that came together in the group and many external partners to kind of bring this together and to work together. And I think and seeing the how so many people have engaged and the report has resonated. So the commission's report has resonated so much across so many different sectors and with so many different stakeholders. And I think that gives me incredible encouragement to see, what kind of progress we can move forward with.
Great. Thank you so much, Carolyn. I'll go to Jen.
Thank you, Elise. So in a similar way to me, the overwhelming positive response this commission has received in all its presentations and outputs, be they, the launch to the national meetings, regional, small group discussions, things being used in teaching settings. There's been just this overwhelming positive response and interest in it. And it feels to me that every small step like this builds to something greater. And that really makes me feel very optimistic.
Great. Thank you. Ibtal?
Yes, I think we start with the composition. I think I am optimistic because as you mentioned previously, the commission is formed with a multidisciplinary, diverse team. So there is a different people from different continent, and also with the specialty, you have people from human right, economic, social science. So you think, I mean, the recommendation and the report are well balanced with this such a group of diverse team. And there is also that the commission looked into items or into topics which has been overlooked for many years. So we had talked about zoom into the aspect of cancer in women specifically, and talking about looking into the power of the women, the decision power of the women, all these items which we want to be visible for the world and need changes. The continuity of the work by creating the monitoring and evaluation, I think this is one of the things which we are, we have to do it because the key recommendation has to be translated into action. And by continuing this work into doing the monitoring and evaluation and creating a KPI, this is also one of the things which has kept me positive and going on. And also, as my colleague had mentioned, the reception which has been taken by a global community since the launch of the report in September 2023 has been extremely encouraging and welcoming. So it's something which has been, the world is, like looking for, and we are very keen on, and interested to continue that work, to change the agenda and to advocate for things which has been overlooked for a long time. Thank you.
Yeah, thank you. Nazik, what's made you the most optimistic?
Again, as Ibtihal said, that we were able to bring issues to the forefront that were never part of the discourse in oncology. With such, we know that there's a lot of emphasis on biomedicine, on just medications or technology, without any reference to how this is affecting actual patients and actual communities across the continuum. So for me, I was really blown away by the response to the gender competency framework, for example, or the fact that people are, they see the value of looking at the workforce, looking at how women are being treated, and that we can actually come with recommendation. We can address the issue. It's not just going to be something like a sense of hopelessness. This is how it is. And then we have the fact that we built everything on a feminist framework. And of course, whenever you mention families, you expect a backlash, but there was a lot of embracing of this. So I'm very optimistic that we have a lot of work to do, but I think we have ground that we had broken. And I think the next generation is really in tune with how the commission and recommendation will be implemented in the real world.
Great. Thank you. Nazik, what's made you the most optimistic?
Again, as Ibtihal said, we were able to bring issues to the forefront that were never part of the discourse in oncology. With such, we know that there's a lot of emphasis on biomedicine, on technology, without any reference to how this is affecting actual patients and actual communities across the continuum. So it's something which has been, very keen on,
Thank you, Nazik. And Rachel, I'll have you round us off.
Yeah, I think there's a bit of an echo in the room. This commission, the sheer accomplishments, the brain power, the passion, the tenacity of the members of this commission it's so inspiring. And also, as a couple people have mentioned, the willingness and determination of the commission to sort of break glass, if you will. I mean, to bring forth challenging issues that people don't talk about a lot, that may often get neglected. I'll say from the economics perspective, feminist economics has been in a ghetto, and people don't talk about it in the profession. But as an example, this commission brought it forward, embraced it, said, this is the way that we need to look at the world, because it is intersectional. And so I think that's what makes me optimistic, is that the Lancet and the reviewers and the members of the commission and the readers and all those who are getting exposed to it are embracing this vision of the world, which I think the commission was very brave to put forth, but nobody's backing away from it. Thank you.
Yeah, thank you so much. All right, we've got about 10 minutes now for Q&A from the audience. So I'll ask folks to go back into Slido if you're not still there, and you can submit your questions there. And anything we don't get to in the next 10 minutes, we'll be able to save, and we can respond offline if needed as well. So there is the join information. And oops, sorry. Okay. So we've got a first question here. Is it possible that measuring and evaluating progress might actually perpetuate an increase in disparities? And how do we avoid this? So any of the panelists want to take that one?
I think it's important to when we measure progress or lack of progress, we have to measure it from the position of empowering those who want to empower. So this, for example, for Black women, gathering data on how they're doing and the outcomes, or Indigenous women, sometimes it shows the disparities, and it may show, and if we don't engage with the community, it may look like, oh, this is just a hopeless case, or it's just like negative stuff all the time out there. But I think if we don't measure the progress, we won't be making progress. So it's important to make sure that those who I am measuring the progress with are engaged with you. They are part of the, so women have to be there, the position of, collecting data. They have to be in the position of analyzing it, and also of implementing it. I think that's how you really make progress out of having the evaluating your what the status of the disparities, and you avoid that, as I said, by empowering those who actually are the equity seeking groups who suffer from these disparities.
Yeah, thank you. Anybody else want to add anything?
Elise, can I add?
Yeah.
So I think if we measure things and we don't do anything about it, it's important to keep everybody involved. But if we measure, we expose something, we don't do anything about it, that just perpetuates, the disparities remain, and we're doing nothing. This is just a waste of resources, really. So I think the why as to what we're doing is really important. And then the importance for it to be an ongoing measure. So by its nature, we don't just measure once and evaluate once. We measure, we figure out there's a problem, we try to do something about it, with the best of intentions, but that may go wrong. So we need to go back and measure again and evaluate. And so it's this iterative process then where we're doing something and addressing things that can prevent that disparity. I mentioned when I spoke about mobile health and how it's been introduced in a number of settings with the aim really of increasing access. But there are many women who actually, in many settings, women don't own their own mobile device. They're often sharing it. And so they might not want certain information put onto that device. They might not have the use of that device at a convenient time. So in fact, that intervention with its best of intention actually could make something worse. And it's only if we do this in an iterative way that we'll pick that up.
Yeah, thank you. All right, I don't see any other questions in the chat, but the joke is on you all as the audience, because that means I am just going to ask you more questions. So as we wrap this session up, I'd love if you could add in a few words, how might your organization help advance this work in its own context? And I know from that poll that Ophira did at the beginning, we have a pretty even distribution of clinicians, advocates, researchers, research funders. I think it'll be interesting to see what the variety of things that you all could do listed here. Give folks a few minutes to answer that. As a first step, have discussions on the commission findings and recommendations. Yep. If you scroll up in the chat, you'll have a link to the full report and the infographic, which is an easy way to guide that discussion as well. And if folks are having trouble accessing the Slido, you're welcome to just type your responses into the chat as well. See a few more folks typing, so finish those up. Continue promoting the value of equity lenses on research, practice, policy, communication, collaboration. Yep, all of those things. I'm glad to see the word continue to suggest that your organization is already doing this as well. All right, I'm going to move on to our last question, which is sort of bringing this home even more. So as you walk away from this session, how will you as an individual, either personally or professionally or both, help advance this work? Just take about 1 minute to answer that question. I see in the chat, collaboration of community organization and discussions of challenges can help. Yep. Recruitment of young trainers specialized in tobacco control, prevention, and counseling. Be mindful of the language I use. Reflect on my language when I interact with patients. Yep. I think we've talked a lot in this session about big high level policy changes that need to happen, but it's important to remember that within each of those international organizations or healthcare organizations or research funding organizations, it's individual people that are actually making the changes. So it's just great to see established M&E in patient-centered cancer care. Thank you again so much for answering those questions. And I think, just because I move this slide doesn't mean you have to stop thinking about it. So we really hope that you take some of these questions home and consider how you can implement these recommendations in your daily life. So to close us out, I'm going to pass it back to Ophira to round off the session. And thanks again so much to our panelists. Really appreciate all of your insights and experience.
Thank you so much, Elise, and to our esteemed panelists and to all for joining us in this session. There's so much to, there's so many people to thank, as you can see here on the screen, but just to say, we couldn't possibly have done this commission without the incredible support of the Lancet, especially our fearless handling editor, Vanya Wisdom, as well as Richard Horton himself, the editor-in-chief, who really encouraged us to go forward with this. And we have been tenacious. I also want to just draw out attention to all the women everywhere who's contributed stories to the Commission's work and who participate in all the research that informs everything we do. And finally, to our partners, including the US NCI, ASCO, Aortic, you can see all of their names here. There's many, many partners, more actually joining in this effort as we go forward. The McCabe Center for Law and Cancer, I'll give a shout out because they wrote an excellent commentary that accompanied the Lancet Commission report, as well as others. Finally, I just want to highlight that the NCI also has an upcoming session, but just before I sign off, a few reflections as you look at the QR code here for the 13th Annual Symposium on Global Cancer Research, that is the US NCI Center for Global Health, our flagship conference that's entirely virtual. We have many hundreds of colleagues from all over the world joining. Please check out and contribute if you like. We have an open call now for scientific sessions, abstracts, and the Perline Award nominations are open as well. You can also see in the chat. But in the last moment, I just want to reflect on the incredible importance of continuing to work in this domain, especially when feminism itself and women's rights are at risk more and more in many countries. We have a lot we can do, but we can only really do it collectively. So solidarity matters. I want to see more of us coming together virtually and in person to have these tough conversations and continue to hope, as we've heard, very hopeful and optimistic comments from our panelists. The mere fact of this commission itself should offer us all hope for moving forward ultimately. Men are a big part of this. We have many male contributors, supporters, advisors. We have a few here who may be online right now, like Professor Richard Sullivan of King's College London, and our commissioners as well, who are part of the solution. So it'll take all of us, but I really feel hopeful that we have a way forward now. So stay tuned for further updates and become part of this growing movement. Thank you so much.